أولاً أنا برحب بكل السادة الأودينس. I would like to welcome you all and I hope you will enjoy tonight's meeting and it will be very fruitful for you all. We have the pleasure to have Dr. Hatem Alawati with us tonight from Oman, and Dr. Samir Panchuli, we have seen him before and we are happy to have him again giving his lecture today or tonight. I'll take 5 minutes just to remind you with the cardiology department in 1982 when Professor Ibrahim Tawfiq, he was the one who initiated and he started and he built up everything in our career in the cardiology department, Al-Azhar University, Professor Ahmed Ismail, Professor Mustafa Said. If you look here, you will find Ali Al-Amin, Hana Atiba, Abdurrahman Sharaf, Salah Al-Abedi, Muhammad Salah, Abu Bakr Siddiq, and Khalid, everybody here. And this is Professor Mustafa Said. He was the only lecturer at that time. Professor Mustafa Said, when he became the head of the department, actually, he revolutionized the department of Al-Azhar University. He took the department to light, and we were able to share in all national and international meetings with the help of Professor Mustafa, who helped everybody in the department. Actually, if I'd like to describe Professor Mustafa, Allah يرحمه, هقول كلمة واحدة بالعربي سوري، أنظف قلب وأطيب قلب شفته في حياتي. اللي ما يعرفوش ولما يشوفه وهو بيشخط وبينطر يزعل منه ويخاف، لكن اللي يقرب من الدكتور مصطفى يشعر ان قلبه اطيب قلب شفته في اسم القلب في كلية طب الازهر. لا نملك الا ان احنا نقول الله يرحم الدكتور مصطفى ويرحم كل امواتنا جميعا يا رب ان شاء الله، ويجزاه خير على كل اللي عمله علشان اسم القلب في الازهر ينهض ويبقى اسم لامع في بين الجامعات المصرية وفي الانترناشونال ميتينجز. الله يرحم الدكتور مصطفى ويجزاه خير عن كل اللي عمله من أجلنا ومن أجل اسم القلب في كلية طب الأزهر. احنا قبل ما نقول what access is the best، احنا عارفين we know that everybody is very keen to have experience in cardiac catheterization. Some people may omit some mistakes that cost us a lot. So the aim of this course is to let everybody know the basis of and the basics of radial access for coronary angiography and intervention, including STEMI and non-STEMI, elective and emergency. So the aim and the objective of the course is to learn how to get experience or enough experience, tips and tricks in performing the coronary angiography and PCI using the radial approach. If we say radial approach, does this mean that the femoral will never be used? Actually, no. Let us think, if you are driving your car, aiming to reach your destination at home safely and comfortably. This is the aim when you drive your car, going home or going any place. Which route you need to or you will choose to go through? The one in your right-hand side or the one in your left-hand side? Definitely, we will choose this way because thinking for a minute or for a second, this is safe, comfortable, even if it is a little bit longer, but it will be safe and wise for us. So safety is always first. Safety is always first. If we are lucky enough, we will find the femoral two femorals, very smooth, without any disease in the aortoiliac and the aorta or descending aorta or abdominal aorta. We will find both radial, ulnar, and brachial very smooth like that. At this situation, you will choose whatever you wish. Right radial, right ulnar, right snuff box, it is a radial, brachial, whatever you wish, or the left side, or you can go to either legs and choose which one do you prefer. But in certain situations, you cannot do that. If you look here on your right-hand side with very extensive peripheral vascular disease like this, you will never be able to achieve your target, and you will never be able to reach the ascending aorta and the coronary arteries. And the only way you will choose in this time will be the radial, even if it is difficult with aberrant origin of the left of the right subclavian, that will take time and effort to cross from the arterial usuria down to the ascending aorta and coronary arteries. Although it is difficult, but it's more safe, and this is the only way if you have very extensive peripheral vascular disease like this. But if you have very smooth, smooth femoral arteries like these, and very complex radial artery loop, why should you, although Mansour will insist to go radial, and he will be able to manage going through this very complex radial loop, but I myself will prefer to go very smooth femoral arteries, very healthy aorta, abdominal, thoracic, and everything. And instead of staying 20, 30 minutes to extend this loop, I'll prefer to go this way. But in the unlucky situation, if the peripheral arterial disease is very extensive, you cannot go at all through the radial, and you have this complex radial artery, it might be the time for the ulnar artery to go through the ulnar artery. So in conclusion, one size does not fit all. We cannot say what is the best access, but we will put what is the best access for this particular patient, and this will be changed from one to one. So please think before you choose, and this requires that you should take a good history from your patient. You have to examine all the peripheral pulses, and you will assess which route to choose and what is the alternative if this fails. Thank you.
Excellent, Prof. Sameh, for this nice, very short, elegant presentation. And I think we can conclude about the safety comes first. However, Prof. Sameh, I would like to tell you about that. Almost everything starts difficult. After that, starts with experience. It comes much, much easier. Thank you so much for this presentation again. Dr. Hatem, Dr. Banshuli sent us a message. He has a procedure right now. So he is willing to start first. We do apologize for that. We actually would like to have Dr. Banshuli with us all this whole session. However, we have to respect his commitments, and we would like to thank him for this valuable time that he's giving to us. So Dr. Banshuli, do you hear us or not?
Yes, sir. Thank you very much. And thanks, Professor Hatem. I appreciate you letting me go first. Are you able to hear me very clearly?
We can hear you, and we are happy to have you with us tonight.
Oh, thank you.
You are very well.
I think I'm sharing my screen, and can you see the screen?
Yes.
Very nice. Okay. So I've been asked to give a lecture today on transradial access. How to do it, where to puncture, why certain things we follow, and then the tips and tricks for the technical success. For those who I have not met before, I'm located in the United States, in the state of Pennsylvania, in a town called Scranton, where I teach medicine and practice interventional cardiology. So let's go right to the business. When we get a patient referred to us for radial access, in the good old days, in the beginning of the transradial access experience, we were taught that we need to make sure that the hand has dual blood supply, and that the two conduits, the two arteries in the upper extremity are collateralized properly. And you might have been told that you should do an Allen's test, modified Allen's test, or a Barbeau test, etc. For those who don't know the Barbeau test, it's somewhat of an objective evaluation of the circulatory pattern at that given time. Um, but the good news now is we have plenty of proof that accessing the radial artery and causing hand ischemia, if you ever do that, cannot be predicted by these tests very accurately, and that the incidence of hand ischemia is so low that we really don't need to pay as much screening attention to the upper extremity. As long as you have a good radial pulse, you can safely access it. If you have an ulnar pulse along with it, that's probably almost impossible to cause ischemia in that situation. The reason is because the upper extremity is not just macroscopically collateralized by the palmar arch, but there are many microscopic collaterals and cross connections that protect the hand and the entire upper extremity from suffering from ischemia if we puncture the radial or the ulnar artery. Now the brachial artery, on the other hand, is considered an end artery, and so there we have to pay very careful attention at compromising flow. But extensive dynamic recruitable collaterals protect the hand from ischemia. So puncturing the radial artery for coronary and peripheral work, the role of screening has been pretty much eliminated, and there is good randomized proof to that effect. This was the radar study that was done by Marco Valgimigli, who was at that time in Rotterdam, and he showed that the patterns of the Barbeau test did not predict the lactic acid level in the blood, etc., in the fingertips. So we'll go right through that and just go right to the technique of radial artery puncture. So when most of us, before we start doing catheterization from the wrist, we are used to puncturing the radial artery for arterial blood gas sampling, etc. And so there we are told to puncture at the point of maximal impulse, which is pretty far distal in the forearm, right around the crease of the wrist. But for radial access, we actually want to go a little bit more proximal. So if you draw a line across the wrist joint, the radial access puncture site, ideal puncture site, is about 2 to 3 finger breadths proximal to that. So towards the elbow from the line of the wrist. And that's very important because the radial artery becomes a straighter artery at that point. I apologize for the formatting, but the other differences from femoral access, when you switch from femoral to radial and you start learning radial, there are some differences. The needle we use is smaller than the femoral. In the femoral access, we use a larger bore needle. In the radial access, we typically use a micropuncture needle or an angiocat type Teflon cannula system that we normally use for intravenous lines. We have two methods of puncturing the radial artery. For the sake of simplicity, we will call the traditional method that we use in the femoral access, we will call it the anterior puncture technique. Anterior puncture is where we only want to puncture the first wall that we go through and not puncture the posterior or the other wall. This is what we do in femoral access, and it's very important. So just to show you a video, I hope it transmits well. I think it should. So we are going proximal to the crease of the wrist by about 2 to 3 finger breadths. We take a 25 gauge needle with lidocaine, puncture the skin just enough to raise a small wheal over there, small prominence with the lidocaine, 1 ml. Not like femoral where we give 7 to 10 ml, but just 1 ml. When I do anterior puncture, I like to use the metallic needle, as I show here in this video. And as you can see, we feel the pulse with the other hand that is not holding the needle. And then we advance the needle through the skin at 45-degree angle. And once we get blood return, we are looking for the blood, so direct your needle towards the pulse. And as soon as you get blood return from the radial artery, we are going to stop right there, and pulsatile blood return will occur. A lot of times you have to fish around, so this was not the perfect case where the first pass led us to have blood return. But once you get blood return, this is what it will look like, pulsatile blood. And you take the micropuncture wire and you advance it. And as you're advancing, you flatten the needle out. You make the needle become parallel to the skin, because we went at 45 degrees. It was not parallel, but we make it parallel. And over the wire, then we put our hydrophilic introducer sheath, which comes in the kit usually, and we can advance it over the wire. So this is the traditional micropuncture assisted anterior wall puncture technique. Now let's go to the more commonly used method, which is the counter puncture technique, where we will go through and through. So again, 2 finger breaths above the crease of the wrist, and same lidocaine, 1 ml. We will raise a wheel, and once we have the lidocaine in there for a few seconds, it should be fairly anesthetized and numb. And then we will take a Teflon cannula here, which is what we call Angiocat in the United States. This is the 20 gauge Angiocat. Same method, we go with palpation of the pulse with the other finger and advance it. And once we puncture the wall, we go forward. As you can see, we went a good few millimeters forward, and we punctured the posterior wall. And now we have fixed the artery with a spear type needle here, and we put the guide wire in the hub of the Teflon cannula after we remove the stylet, and we very carefully pull the needle, the Teflon cannula back, and once we get continuous blood return, we will go ahead and advance the guide wire. This method is easier to learn. Now in this patient, we had a very tough skin, so we are making a very small incision with an 11 blade. And as you can see now, we are advancing the 5 French hydrophilic sheath over that wire, similar to the other technique. So counterpuncture technique, where the 2 walls are punctured, and anterior puncture technique, where we only puncture the wall that we first encounter and then we stop. So why go counterpuncture? Let me, with the help of some of the schematic diagrams or cartoons here, show you why. So as you can see here, the artery, and we have the counterpuncture, the Teflon cannula going at a 45-degree angle. We go in the first wall, and we continue to advance, and we puncture the posterior wall. We remove the stylet. Then we tend to pull the cannula back in the same plane normally. But what we want to do is really bring the cannula close to the skin and then start pulling back. And as you come back from the posterior wall in the lumen of the artery, you will see pulsatile blood flow coming from the back of the hub of the Teflon cannula. And then we advance the guide wire. And this usually allows you to put the guide wire in the lumen. It does not go subintimal, because the entry is very clearly from the posterior wall into the lumen, very controllable. Now, with the anterior puncture technique, we need to advance the needle very coaxially or very flat, so that we don't puncture the subintimal space with the guide wire. So the difference between the counterpuncture, where we can go at a steeper angle and then still end up coaxial to the lumen, whereas anterior puncture, you need to puncture coaxially. And that's why it takes a little bit more skill to learn the anterior puncture than to learn the counterpuncture. One other angiographic demonstration of the 2 techniques. So you can see here the counterpuncture technique, and I'll magnify this picture here. And as you can see, my tip of the cannula is actually in the back of the artery almost. So posterior puncture is already established. The axis of the artery is there. This is the axis of my access. We will make it coaxial, and we will advance the guide wire. Let's look at it more clearly with ultrasound. This is a very interesting picture. As you can see on the right side of the screen, you will see my needle come in, and you can see right there it went through the posterior wall. I'll play it again one more time to see. Watch this part here. The Teflon cannula with the needle comes in and punctures right over there. You will see it as it goes through the wall right now. So that's where the cannula entered. Now when we pull the cannula back from the posterior wall into the lumen, here is the cannula, and it's coming back from the posterior wall and you can see the artery drops out of the tip of the cannula and the guide wire goes in. I'm going to play it one more time for everybody to see, because this pullback from the posterior wall is very, very important. So here is my cannula. Right there, you see it now, both walls, posterior wall where my hand is, and then you can see the cannula left the posterior wall. And now from there, you advance the guide wire. Very controllable movement as opposed to anterior puncture where it's a little bit more difficult. Let's talk a little bit about ultrasound guided access. So two things are important with ultrasound guided access. You have to get used to holding the ultrasound probe in your opposite hand without moving around and gliding around. So you can see a very good, clear and stable image of the radial artery on your screen. The other thing to importantly note is the center point of the ultrasound probe. There is a little black marker here that you see on some of the probes, which you can see through this glove that is put on the probe, which allows you to make it sterile. So know where your center marker is. That center marker is where you want to place your artery on the screen. So right there, this blue dot and this blue line is where the center of that probe is. You can see our radial artery is right in the center of the screen, and so it's under that central marker. And what you saw there is my needle puncturing it. It'll completely deform the silhouette of the radial artery. And as I advance the needle, you can see now it's all completely messed up, as we call it. And so that's where the cannula is going through. And on the other side, on your hand, you will see blood in the back of your cannula because you punctured the radial artery. Now you're coming from the posterior wall into the lumen of the radial artery. So we put the wire enough length ready to go in the lumen, and we very gradually pull this Teflon cannula back, and once we get continuous flow, we advance it. So once you have that place, you can get access. Now, one of the concerns that we had initially when we started using this counterpuncture technique, which was so much more easy to learn and so much more successful on the first attempt, is the criticism was that because we are puncturing both walls of the radial artery, that we are causing more trauma, and so we will have a higher rate of radial artery occlusion. Well, we studied that in this randomized controlled trial called the RATE trial, where we randomized patients to the through and through technique versus the one wall technique. And what we found was that there was no difference in the radial artery occlusion rate or the hematoma rate. So it was very reassuring to see in a fairly large cohort, 400 plus patients, that the complications were not anymore with the double wall puncture as opposed to single wall puncture. Let's talk a bit about a few other things that are important to learn when we do radial access. Some of the radial specific issues that happen when you puncture the radial artery and put a catheter in it. The first thing to know is the spasm. Radial artery is significantly more likely to go into spasm compared to the femoral artery. Why is that? Well, it has a much higher density of the alpha sympathetic receptors in the media, which is the muscular wall. So it goes into spasm if it has any tactile stimulation. Now, it also has a smaller diameter, and so there's a larger probability of tactile stimulation because you are touching more of the inside of the radial artery. So because of these two characteristics, the radial artery develops spasm. And because of the spasm, we need to give a cocktail. We will talk about it. So the risk factors for more spasm are a smaller radial artery in a short patient. Female patients get more spasm. If you use a non-hydrophilic introducer, you will get more spasm. This was seen by Rathore and his colleagues who published this in JACC Intervention about 10, 12 years ago. And then if you use large bore catheters, then you will have a more probability of spasm because of the larger overhang and the unfavorable transitions between the catheter and the artery. So this is what your catheter looks like when you put in, and there's a whole area which kind of plows through the radial intima and goes in and causes trouble. Solutions are pharmacologic and non-pharmacologic. So the non-pharmacologic solutions are use a hydrophilic sheath. So use a sheath which has a slippery coating on it. It's been shown to cause less spasm by Dr. Saito's original study and then a randomized trial by Sudhir Rathore. It also is associated with increased comfort, less entrapment, and possibly less radial artery occlusion, although there is no proof of these last two things. The better transitions, if you have a large catheter that you want to put in, like a 7 French guide, put another catheter in it with a telescoping mechanism so you have less razor effect or less surface contact with a sharp surface. You can also achieve this with balloon-assisted tracking. This is how you can achieve the improvement of transition. So if the guide wire is coming out of this large catheter, you can put a smaller catheter through it to make a nice step ladder type of transition. Or you can nearly eliminate the transition by putting a balloon. And as you can see here, there's virtually no transition. It's a very aerodynamic type of a smooth tapering system. And so you can use either one of these methods. Now, spasm can also be treated or prevented by using vasodilators or the pharmacologic solution. We commonly use the vasodilator cocktail, as we call it. In my lab, we use nitroglycerin, and we also use the calcium channel blockers. You can use diltiazem or verapamil, and these are typically administered intra-arterially so that they have a high local effect and low systemic effect. Another very, very important constituent or necessary member of the cocktail is the anticoagulants. So unfractionated heparin is almost always used in radial access. It's very dangerous to do radial access without giving heparin in the cocktail. Why? Because it prevents radial artery occlusion. At least 50 units per kilogram or 5,000 units, and there's plenty of data for this. Christian Spalding in 1997 observed this initially, and then it's been corroborated by the Leipzig study and Bernard's study from Czech Republic. You can give it intra-arterially or intravenously, and it does not have any difference in the effect. We showed that in 2009 with a randomized control trial. But heparin is a very important necessity in radial access, and enough heparin is very important. So you have to give the right dose. If you give a lower dose, you get a much higher rate of radial artery occlusion. So the 2,000 units is worse than 5,000 units. That was shown by Burnett in 2013. The higher the dose of heparin, the lower the rate of radial artery occlusion. So if you go from 50 units to 100 units, as shown by George Hahalis and his group from Greece, you can further lower the risk of radial artery occlusion. Now, some people would argue and say, well, there's a much higher bleeding risk as you go high on the dose, and that is correct. So we are not recommending using 100 units per kilogram for, let's say, diagnostic procedures, but the minimum necessary heparin is 50 units per kilo. Anything less than that would not be a very advisable thing. There is a J-shaped curve, and so if you give more heparin, you will see more bleeding, and you will see actually a higher rate of radial artery occlusion. This was a very interesting study from last year from Circulation Intervention, a very good study, where it showed that as your ACT goes up, the radial artery occlusion rate actually increases if you have a very high ACT. Why? Because you need to compress longer and you compress harder, and that's what makes you get a higher rate of radial artery occlusion. So, the effect of anticoagulation is not restricted to heparin. It has also been seen with bivalirudin. So it's a class effect, as we call it. But heparin or bivalirudin should be used. Warfarin, on the other hand, is not enough to prevent the radial artery occlusion. If you take patients with warfarin without heparin, there is a significantly higher incidence of radial artery occlusion compared to those not on warfarin who got heparin. So this was our data from a few years ago, where we showed that warfarin alone is not enough to prevent radial artery occlusion. So it is okay to do a radial cath on a patient on warfarin without stopping warfarin, but you have to use heparin with it. And it does not cause excessive bleeding, and it does help keep the radial artery open. So radial artery uh, puncture, use dedicated equipment, use counterpuncture. It is faster to learn and it gives you a higher first attempt success. Use a hydrophilic introducer sheath, use a spasmolytic cocktail, use anticoagulation. And if you use all your available tools, you might have a lot of tools, but if you don't use them right, you will never get over the hurdle. So proper use of all these tools will give you the best possible access. Thank you.
Great.
Any questions, please?
Excellent, Prof. Pancholi, about this elegant presentation. As usual, let me just tell you about my practice with a little bit, maybe a little bit difference about what you said right now. Starting from local anesthesia, you mentioned clearly that you just localize the anesthetic area. Usually when I give anesthesia, I mix xylocaine with nitroglycerin a little bit. And usually I extend this local anesthesia to approximately 3 centimeters because, as you are aware, sometimes focal spasm happens. When I see focal spasm, usually I can go a little bit proximal, so it helps me a lot. What do you think?
Yes, absolutely. So, nitroglycerin, there is clearly some data that if you give nitroglycerin along with lidocaine, then it will facilitate the success of radial access. Actually, the story of nitroglycerin goes back to 2004 when I was learning radial from Dr. Patel from 2002, and we used to get a lot of spasm because we were puncturing too many times. We were not very good at getting access. So we started giving subcutaneous nitroglycerin. We were giving nitroglycerin under the skin in the radial artery area to relieve spasm. And then somebody from Italy actually did a study where they showed that if you do it up front, it actually helps you even more. So I believe in local nitroglycerin. I think it's a good idea. And even anesthetizing more proximally is not a bad idea because the pain response causes the spasm. The pain is what causes the spasm. So if you can alleviate the pain, you will get less spasm.
Okay, in our region, a little bit different from you. You said the counter pulsation is the commonest one, but here we are using the anterior in vast majority of our situations. For example, I used the counter pulsation for a few hundreds only, but I used the anterior puncture for almost thousands of patients of radial puncturing. What do you see? What is the main difference from your point of view? The counter pulsation is better. I used it because usually I can inject this, nitroglycerin, and it helps to alleviate spasm by the cannula, by the counter pulsation better. Do you see any more advantages of the counter pulsation compared to anterior?
No, actually. So, what I tell people is that if you are able to do anterior puncture and you don't have any problems with obtaining access, then anterior puncture is at least as good as counterpuncture. The only time I recommend counterpuncture is when somebody is having a difficult time with the anterior puncture, and if they're having multiple attempts, then I think they should switch to counterpuncture because it has a more reliable, predictable, success rate.
Last question to you. Just 2 months ago, I experienced the patient or encountered with the patient with STEMI, and this patient was on warfarin. INR was 2.2. I used the radial approach as usual. It's the 100% of my patients, and I gave heparin with INR 2.2. What do you think about this? Shall I give heparin also with INR 2.2, or yes, what's your practice?
Yeah, so we studied our local data, and we also got data from the Quebec City lab, and we looked at patients who are on therapeutic anticoagulation with warfarin, and they have a fairly high radial artery occlusion rate if you do not give them heparin. And so that's when we started to recommend that everybody who has a therapeutic INR should still receive heparin when they have radial artery puncture for access. Now, we were worried about bleeding, but now we have over 1,000 patient experience where we have given heparin to patients with a therapeutic INR, and we haven't seen any non-access site or access site complications because of that.
Okay, Prof. Sameh, Dr. Hatem.
We have certain questions. Mahmoud Osman said, in case of weak radial pulse and after giving local anesthesia, we cannot feel it well. Can we just puncture radial artery and passing wire, then give good local anesthesia before sheath insertion? Oh.
So that's an interesting question. So, I know some of the operators around the world who do not give local anesthesia in the beginning. And those operators are extremely good at obtaining access in the first attempt. So I think if you have a weak pulse, I would advise using ultrasound because that will give you more visualization and improve your success rate. The other trick you can use if you have a weak radial pulse is compress the ulnar artery and the radial pulse will get stronger. So if you compress the ulnar artery, if your assistant can compress the ulnar artery, the radial artery pulsation will get larger.
That's good. We have one more question. How can we use heparin with warfarin and R/2? It was answered. Hoda asked why not use ulnar artery. We can use ulnar artery, and there are few lectures coming. We will discuss when to use ulnar artery. Dabash, is it routine to give anticoagulation in all cases, diagnostic and PCI? I think the answer, the question has been answered, and to keep the patency of the radial artery, you have to give heparin even if the patient is on warfarin.
Yes.
Okay, we don't have, okay, unfractionated with vitamin K, I, and R.2. Will post-procedure compression differ according to the method of the puncture? Dr. Muhammad Iftar is asking,
Yes.
anterior puncture or counter puncture is a method of post-procedure compression differs? I don't think.
No, it's the same actually. Yeah, it is exactly the same.
Okay. Ala Nasr is asking, should we fix the wire during the sheath introduction? Should we fix the wire during the sheath?
I would do the same thing you do from the groin access, where we hold the wire outside and advance the sheath.
Just to avoid escape, the wire will escape with the sheath and the elator. I don't know if this is the answer or not. Any more questions? Thanks very much.
Dr. Hatem would like?
Thank you again.
I'm good. I have no questions. Thank you so much. Fantastic talk.
Dr. Panchuli, could you please tell us about the global utilization of radial approach in USA right now?
In the US, it has crossed 60% now from what I was told by the national societies. So it has come a long way. It came from 0.5% when we started to 60% now. So I think
that's good. Excellent. You will encourage us to do more radials now.
Absolutely.
Yes. Okay. Thank you very much, Dr. Panchuli. We were very happy to have you and looking forward to seeing you next time, inshallah.
Thank you.
Okay. Thank you.
And if you finished, Dr. Panchuli, please, if you finished your procedure, I think you can join us again with this interesting talk by Dr. Hatem. He will give us a presentation right now, how to prevent the catheter kink, and if noted, how to release it. It will be interesting talk. If you have time, we will be very, very pleased.
He left him also.
Okay. So it's time for Dr. Hatem right now. It's floor for you. I think we will be pleased by your presentation, Dr. Hatem. Last week, I gave a presentation about subclavian tortuosities. One of the most important complication or anticipated complication of this is catheter kink. And in severe situations, it may be completely knotted. So how to prevent kink and the knot, of course, and how to release the kink. So how to release the knot. So I think this is Dr. Hatem time right now. Please, Dr. Hatem.
Good evening, everyone. And at first, I'd like to thank Prof. Mansour and Prof. Sameh for this generous invitation for me to participate in their elite radial course. And I feel particularly honored and privileged to have my name paired with an icon and a legend in the field, that is Professor Sameh Pancholi. So thanks for the opportunity. It means a lot to me. I was tasked to talk about a situation that is uncommon, but nonetheless, we do encounter it from time to time. A situation that in the past would have required a surgical intervention. And I'm going to try and convince the audience that with time and as we continue to develop our skills as interventional cardiologists, we too have become experts in close reduction with internal/external fixation, except that we do it slightly more creatively compared to our colleagues, the orthopedic surgeons. And I'll try and convince you of that. My name is Hatem Melawati, and I have no disclosures relevant to the topic of this presentation. So it was one regular day for me in the cardiac cath lab. I was going through my list of cases, and I was nearing the end of the day when one of my colleagues walked in. And he said, Hatem, could you please accommodate this one extra patient that I admitted earlier today from the emergency department? He's a young guy, and I think he has an acute coronary syndrome. Thinking to myself, you know what, it's one more case, no harm done. It's going to be straightforward, young guy, except that in life, nothing really is straightforward. The case was that of a 34-year-old young man who presented with a 2-day history of stuttering, typical ischemic sounding chest pain. The pain was retrosternal and radiated to his left shoulder. He never had this pain before. At the time of his initial evaluation after sublingual nitroglycerin, he was chest pain free, clinically stable, no signs of heart failure, essentially an unremarkable cardiovascular examination. His past medical history was significant for diabetes, for which he was on insulin. He was previously diagnosed with HIV infection, but was not on treatment, and also a primary psychiatric problem for which he was not on treatment either. So clearly the man was non-compliant. I'm showing you his 12-lead ECG, which I think we'll all agree looks pretty benign. Some of us might argue saying that, you know what, there are some subtle ST elevations in AVL, perhaps some skewing up in 1, depression in 3, maybe ST elevation in V2. Are we talking about the South African flag sign? Maybe, but the ECG remained static over the course of the few ECGs that were done since his presentation to the emergency department. So he had a series of ECGs and they all looked the same. Moreover, his troponin I, this is the assay we used at the time a few years ago, level peaked at 1.1 micrograms per liter. So clearly abnormal, but that's just a modest elevation compared to the upper limits of normal. And more importantly, his transthoracic echocardiogram revealed normal left ventricular ejection fraction with normal resting LV wall motion and normal valvular apparatus. So we brought him down to the cath lab. I established access in the right radial artery, got my standard 35,000th of an inch guide wire up the arm, and then I encountered a little bit of resistance. No big deal. Got my Tiger catheter up that wire and gently negotiated my way over the subclavian tortuosity into the brachiocephalic trunk into the proximal aorta, and with the deep inspiration, the wire and the catheter both fell into the aortic groove. We all see this all the time, and we don't think much of it. A little bit of tortuosity, no harm done, we crossed it, when in fact, the anatomy can actually be more ominous. Very similar to this 3D reconstructed image where the subclavian follows a very tortuous course, as well as the brachiocephalic before they actually enter into the arch. So this is an early warning that you should really be careful from here onwards. Well, I wasn't. My catheter fell into the aortic cusp, engaged in the right coronary artery. I started selectively injecting the right, and I think we all agreed that this is a a small non-dominant disease-free right coronary artery, essentially one long RV marginal branch that extending all the way down to the distal RV free wall. Okay then, time for me to engage the left coronary artery. So I clock the catheter, and something funny, the catheter is not behaving the way it should. And every time I clock it, the pressure tracing changes. So I got a little frustrated, and I clocked and I torqued and I anti-clocked, and I'm trying to get into the left coronary cusp, and then all of a sudden my catheter stopped responding, and the pressure tracing damped altogether, and it stayed damped. Wasn't sure what was happening, so on fluoro, I realized that I'd done this. So I've not only kinked the catheter in multiple places, but I've actually twisted it around itself at least twice, here and there. Okay, what to do now? I thought, okay, maybe let me pull the catheter back into the subclavian. Maybe pulling it back will straighten it somewhat. Then I can get my catheter, my wire across and straighten it. That didn't work. If anything, it induced a lot of pain in the right shoulder area, in the subclavian area. So I stopped, I pushed the catheter forward, and it fell into the descending aorta, as you can see. So now what? I put myself in a very difficult situation. Manipulating catheters like these across the subclavian artery can be problematic. If the operator is not careful, you can induce a lot of potentially life-threatening complications. You can tear the subclavian artery. It can rupture, and the local rupture can be contained in the form of a pseudoaneurysm, or you can have an active extravasation into the mediastinum, which can be life-threatening. We all heard this brilliant talk by Professor Allam last week, where he talked to us about the major branches coming off the subclavian artery from its first segment, the mid segment, and the third segment. Now imagine manipulating a kinked catheter in the subclavian, trying to unknot it, and then you pick off the ostium of the vertebral artery in an elderly man with diffuse atherosclerosis and probably sclerosed cerebral arteries, and you induce acute vertebrovascular insufficiency. So there is a lot of room to cause complications when you're not careful, aside from dissecting the main vessel or its main branches, or causing a localized rupture of the subclavian artery with the ensuing complications. You can even precipitate a mediastinal hematoma or a neck hematoma within the confined space of the head and neck. If a hematoma accumulates very quickly from an arterial bleed, you can imagine how bad the compressive effect can be on the upper airways and the esophagus. So really the consequences can be pretty dire. And I think looking at this video, we begin to understand why that would be. You're converting a slender catheter, a tube-like structure, into a stiffened, irregular, deformed catheter with sharp edges. And as you can see, the operator here was able to straighten the catheter by, number one, fixing the distal tip. Number two, reversing the movement that resulted initially in kinking of the catheter. It's oftentimes a gentle counterclockwise torque, while maintaining gentle traction at the free end of the catheter. And with that, he was able to successfully unkink the catheter. The challenge is, how do you achieve this in vivo? We interventionalists, as we become more adventurous and become creative in snaking our catheters across tortuous subclavian and brachiocephalic arteries, put ourselves in the situation where we encounter problems like shown in the next video, courtesy of Professor Allam, where you actually kink the catheter with overzealous manipulation. Operators from all around the world have described very creative ways of trying to get over this problem, and they describe various different methods to untwist, unkink catheters without needing to resort to a surgical approach. One of the earliest descriptions was courtesy of Professor Patel and Professor Pancholi, where they used a very simple, handy technique, a simple blood pressure cuff. Here they described a catheter that was kinked in the radial artery. There was a lot of catheter up in the brachial artery. They They tried to get a wire across, they couldn't. So they just put a blood pressure cuff over the brachial artery, externally fixed that part of the catheter with a cuff inflated to 200 millimeters of mercury. And then with the free end of the catheter, untwisted it, got a wire across, and extracted it from the radial approach. Very simple, very handy, and it worked. This Turkish group tried that external compression technique, which didn't work in their case, so they became more creative. They actually fixed the proximal part of the catheter with a needle, the one that you typically use for intramuscular or intravenous injections. They punctured the catheter under fluoroscopic guidance at the elbow, and they pinned it there. Having fixed it proximally, they then untwisted the catheter at the free end. They managed to unkink it, got a wire across, and extracted it. This Japanese group, I think we all agree, got themselves in a real situation here with a guide catheter that was badly deformed, kinked, and twisted right at the elbow. They tried external compression, did not work. So the external compression was manual, obviously. So then they thought, okay, let's try and pin the catheter internally. So they got femoral access, they got the guide catheter up in the subclavian artery, and then they got a 3-5 semi-compliant balloon, inflated the balloon here and pinned the catheter, but that wasn't enough to fix the catheter. But when they combined external and internal compression, they were able to then fix the distal tip enough for them to be able to untorque it and then put a wire across and extract it from the radial access site. This particular group got a catheter badly deformed in the radial artery. They tried to get a wire across, wouldn't work. Untwisting it induced a lot of spasm, and the catheter was literally fixed in the radial position. They got access in the femoral artery, but the guide catheter was too far. The tip of the guide catheter was too far from the deformed catheter. They got a guide liner down, extending their femoral guide catheter another 25 centimeters, which got them to the kinked catheter. They managed to snare it, bring it up into the subclavian where it's more spacious, bring it down into the aorta, which is even more spacious. They snared it with an end snare, fixed it there, untwisted it, got a wire across, and removed the catheter. This group did the same, except they used a gooseneck snare, not an end snare. This particular group of operators described a very unique way of untwisting catheters through the same approach without needing to get access in the femoral artery. Essentially, they kinked a 5-French catheter in the brachial artery. They tried to get a wire up that kinked catheter. They weren't successful. So what they did is they cut the kinked catheter. They removed the standard 11 centimeter long sheath. They cut the kinked catheter and used it as a guide wire. And over there, they put a long 5-French sheath, snaking it up. Once the guide catheter got to the kink, with gentle forward pressure and traction on the kinked catheter, they straightened it, they ensheathed it, internalized it in the sheath, and took everything out as one unit. So from one single access site. This particular group had a badly mangled catheter, deformed and twisted, and they were able to extract it using an end snare. And then working from both ends, they were able to remove the catheter. I would recommend the audience to refer to this paper, which nicely summarizes most of the techniques described in the literature on how to reduce deformed catheters without needing to resort to surgical intervention. So in summary, you would consider external fixation either with a sphygmomanometer blood pressure cuff or with manual compression. You may use an oversized sheath to on a truncated kinked catheter and extract it. And for the same indication, you can use a sheathless guide. If it's a simple knot, you can even unravel it by connecting it to an indeflator and cranking up the pressure gently. The hydraulic pressure then straightens the kinks and allows you to remove the catheter after you've passed the wire through. And lastly, fixing the distal free tip of the catheter with a snare kit, either a gooseneck snare or an end snare. And then there is a very nice algorithm suggested by the writers where you go through them in a stepwise approach, which makes a lot of sense to me, at least. What is more important than actually fixing the problem is how to prevent it. One of the recommendations is to use dedicated radial catheters or guide catheters, which are supposedly more kink resistant. Having said that, in my experience, the case I presented, I actually used the Tiger catheter, and miraculously, I managed to kink that, a dedicated radial catheter. The second point requires a conscious effort from the operator to try and avoid over-torquing the catheter. And sometimes in the heat of the moment, when you're frustrated dealing with so many tortuosities, you just lose track of how much you've torqued the catheter and end up realizing that you've gone several folds overboard and ended up with a kink catheter. The third point is a standard operating procedure. You have to have your eye on the pressure tracing all the time and watch for any changes. The fourth point has actually become my practice since this case. Whenever I encounter a subclavian tortuosity, I actually go in with a guide catheter with a standard wire in the guide catheter. And that serves two purposes. There's a wire in the guide, so it stops it from kinking or twisting. And number two, it stiffens it, so it improves torque transmission and allows you to better manipulate the catheter. We can't stress enough how important it is to make sure your patient is well hydrated, sedated, and the use of spasmolytic agents as highlighted by Prof. Pincholi in the previous talk. And then of course, referring back to the very wise pearl that was offered last session and the session by Prof. Allam, patient safety always comes first. If you think it's too adventurous for you to negotiate that tortuous subclavian, just cross over to the femoral approach and do what's safe. So what happened with our case? So flashback, this is where we left off. So to summarize, I have a badly kinked, twisted catheter, which I'm not able to retrieve back into the subclavian because it's too big and it's causing a lot of pain and I don't want to dissect the subclavian. And the tip is floating freely in the descending thoracic aorta, and I can't get any wire across. I couldn't get a 35 thousandths of an inch wire. I couldn't get a 38 thousandths of an inch wire. I couldn't get the reverse end of the wire. I tried coronary guide wires, hydrophilic wires, nothing would negotiate this mess that I've created. So I had no choice but to get access to the femoral artery. I punctured the right femoral artery and got a multi-purpose guide up to the distal tip of the deformed Tiger catheter, and I delivered a 4mm gooseneck snare. I captured the distal tip and I tightened my grip. And then working from both ends, I managed to unravel and untwist the catheter ever so slowly, ending up with this little kink at the end. And then I put my standard 35 thousandths of an inch wire and slowly straightened the kink, got the wire across all the way down the tip of the Tiger catheter, released the gooseneck snare and externalized the wire, and managed to extract it from the radial approach. No harm done. Now remember, we haven't finished the case yet. I've only studied the right coronary artery. And I'm not a die-hard radial interventionist. I think if it was Professor Mansour in my place, he would have still gone up that arm, negotiate that subclavian back into the aortic root to study the left coronary system. But I thought, you know what?
Already you have femoral. Already you have femoral.
I have femoral.
Yes.
Exactly. So that's what I did. I engaged the left system with a guide catheter, thinking that I'll find the culprit to treat. The left system is dominant with a very extensive network of obtuse marginal branches in the dominant circumflex. I don't see any culprit there. There was no evidence of significant disease in the LAD. The culprit was probably a hazy lesion in the ostium of the medium-sized diagonal branch. The flow is relatively normal. And we thought, you know what? He's chest pain-free. The troponin leak isn't that bad to begin with. LV function is normal. Treating this with a stent, you may compromise the much bigger disease-free LAD. Moreover, this young man is non-compliant. We don't want to commit him to a stent for him then to stop his dual antiplatelets and come back with acute stent thrombosis. We decided to stop there after that adventure and commit him to medical therapy. The patient did very well, stayed in hospital for a couple more days, remained chest pain free. There was no forearm hematoma. His chest x-ray was completely fine. There was no widening of the mediastinal silhouette, and he was discharged in a stable condition. And as expected, never came back for follow-up.
Yes.
So I hope towards the end of my talk, I managed to highlight to our audience a stepwise, relatively systematic approach to how to troubleshoot a kinked catheter introduced from the radial approach, and more importantly, how to prevent this problem in the first place. Thank you.
It was a fantastic, or I think I cannot find proper words just to give this presentation. It's right. Is it outstanding, magnificent, or whatever? I think it's a fantastic, very, very nice presentation as usual and as expected, Dr. Hatem. Yani wallah. I think you did your best to look for the literature review, and I think you got a very, very good experience in that. And you are the one who gets more and more experience by this review of literature. Many of these reviews I didn't read and I didn't hear about actually. Very, very, very nice. So I think many attendees right now, they are raising their hands and they are appreciating this nice case, nice presentation, and the nice presenter as well. So I think I will open the floor for the questions, for asking, or for whatever you do. So Prof. Allam, what would you like to ask? Would like to say anything, Dr. Prof. Allam? Prof. Sameh? I think Prof. Sameh maybe left us, or he didn't hear us.
No, I'm here, ya Mansoor.
So please.
Do you hear me now?
Yes,
yes,
I can hear you, Prof.
Okay.
Very well. Yeah.
I think Dr. Hatem has highlighted very important points. Actually, if you are manipulating your catheters from the radial or from the femoral approach, you have to be very cautious during making a torque. And you have to observe while rotating your catheters outside how much torque you have done and how much torque has transmitted to the tip of the catheter. This is very important points. Watching the pressure from the tip of the catheter is a very, very crucial point, because once a knock or a knob occurred in the catheter, you will lose your pressure outside and the pressure will be dampened. Then you will stop early. And if you feel that you are doing your torque, but it is not transmitted to the tip, just have a look on the entire contour of the catheter from the inlet to the outlet to see where the problem is. These are very important points, either going through the femoral or going through the radial. But actually, I enjoyed it very much. At some time, my blood pressure rose up and I got tachycardia, but at the end, it was very successful. It's a nightmare, but actually it was very successfully done, alhamdulillah, and it's a great job. And I have to admit that using your mind in the cath lab is very, very important. I have never heard about just applying outside cuff pressure just to fix the distal segment and rotate while the other, the distal segment is rotated. Very simple, but it's a very mental work, actually. Thanks very much, Hatem. I enjoyed it very much, and we thank you very much.
My pleasure, Prof. Thank you so much.
Dr. Hatem, I think as you are aware, the materials of the diagnostic differs from the guiding catheter. Did you experience or did you hear about any guided catheter kink or not? And how do you do? Because I do expect that it will be, I think it seems to be very, very complex. Not if happened with the guided catheter.
That's very true indeed, Prof. Mansoor. I've actually kinked all sorts of guide catheters. At our cath lab, we have two different providers for guide catheters. Medtronic launcher, and then we have the cordless guide catheters as well. And I have kinked both of them. And for some reason, it's always the right coronary guide catheter that I end up kinking. And I think it's more than just the material of the guide catheter. It's how the operator deals with the tortuosity and how much patience they have. You know me, I tend to be impatient. If there isn't much torque transmission, I just keep rolling the guide catheter. But yes, you can experience this with any diagnostic or any guide catheter you use. There's nothing kink resistant per se.
Yeah, I think you're okay. Please, Prof. Allam.
Actually, I have found it actually helpful. If you are manipulating your catheter and you find some resistance, just put the guide wire and leave it near the tip of the catheter, diagnostic or guiding, and rotate your catheter. The presence of the guide wire inside the catheter will harden it, and it will help to transmit the torque down to the tip.
Absolutely, Prof. And my threshold for doing that has actually gone very low. Anytime I encounter some tortuosity, my immediate strategy is, let me get a wire down, and then I'll torque my catheter. And I oftentimes exchange out the diagnostic for a guide, because then I have better control for some reason with a guide catheter with a wire inside than a diagnostic catheter with a wire inside.
Do you usually use 260 guide wire or the shorter one when using the radial approach?
I always use the 260 centimeter guide wire when I'm going up the arm.
That's good, because if once you are in, you will be in all the time. I think 260 should be used routinely even during the diagnostic catheters. I prefer it actually. Mansoor?
Dr. Hatem, I think I have been asked, or Dr. Sameh, Prof. Sameh has been asked from one of audience 2 sessions back. They said that with these all complications with the radial approach, we still have to go to radial approach. I think femoral is easier and safer, or bigger, and everything. So how do you answer them after this catastrophic event that I think solved in a very, very nice way?
Right. So I don't think these complications should deter us from using the radial approach for our coronary interventions. I think, Prof. Mansoor, you are planning a few sessions coming up with very eminent speakers on the clinical evidence comparing the use of radial approach to femoral approach in coronary interventions in various clinical scenarios. And the evidence is very clear. The risk of bleeding complications is much lower than the radial approach. The reason why we're facing these complications now is because we've become very comfortable with the radial approach, and we've become more adventurous, and we are willing to try out more tortuous anatomy. And that's just the nature of the business. The more skillful you become, the more hurdles you encounter. And it's just a matter of having the right state of mind, having always a plan B for when you encounter a problem. What do you do about it, and how you troubleshoot it? It should not stop us from using the radial approach, because just like you heard Prof. Pancholi saying but maybe a decade ago or a decade and a half ago, the rate of utilization of the radial approach was only 0.5%, and it's grown up to 60%. In the face of the clinical evidence supporting the use, that is just the way to go. This is the culture that's taking over our interventional field.
Actually, the learning curve. Sorry, Mansoor. Go ahead.
No, please. No, please, Prof. Sameh, please go on.
The learning curve of the radial approach is probably slower. So we should be patient enough to get enough experience, and we should not get frustrated from just a complication or so. The learning curve, we understand that. And it was observed in many studies that the radial artery is the learning curve is longer than the left radial artery because of the tortuosity and because of the kinks and so on. So following the basics, the basic science of any technique, you will be able to overcome, to avoid the problems. And if it happens, you will be able to realize it, recognize it, and you will be able to manage it. So we have to insist to learn on scientific basis.
Just to reiterate what about Dr. Hatem mentioned right now, next week, inshallah, we will have one of the eminent interventional cardiologists worldwide class, the Prof. Sunil Rao. He will be with us to talk about STEMI, segment elevation myocardial infarction, and radial approach. He will present 3 cases, inshallah, next week. One of them is a simple case, a routine case. Second one was a little bit challenging, and the third one will be markedly challenging case, just to see how to solve and how to deal with such situations. Also, it goes with the patient safety, so that we have to keep in our mind, as Prof. Sameh mentioned in his presentation, safety comes first. And I would like to say also, all these issues should go on evidence-based. What we are doing in our course right now, I think, is the evidence that you provided today. Okay, how to retrieve a kinked catheter on evidence base. Okay, so I think this course, I think it goes in a proper way that I see right now. What do you think?
Great. Hatem?
Absolutely. Absolutely.
Okay. Should we end so if there
are
we don't have any more questions. Probably we have Mohammed Nabil. This is the last question. How can you capture the distal end of the twisted catheter with multi-purpose catheter? How can you capture the distal end of twisted catheter with multi-purpose catheter?
So the twisted catheter was in the descending thoracic aorta. And the multi-purpose catheter that I used was actually a guide catheter. So it's a multi-purpose guide catheter. I delivered it in the aorta to the distal tip of the catheter through a standard guide wire, a 35,000th of an inch guide wire. And then through the multi-purpose guide catheter, I introduced a snare kit. You can use an end snare, or you can use a gooseneck snare. And that's what I had available in my lab at the time. It was a 4mm gooseneck snare that I opened in the aorta, and then I captured the tip with and was able to grab it. Obviously, it wasn't from the first attempt, because as you can imagine, you have a catheter that is a 3-dimensional structure floating in the descending thoracic aorta, and I'm using 2-dimensional imaging system to try and capture it. So it did require a couple of attempts before I was able to actually grab it. If you don't have a snare kit in your cath lab, one thing you can use is a biopsy bioptome if you're doing endomyocardial biopsies, but that will require a bigger sheath. You can grab it with the bioptome and fix it that way, or you can improvise a snare. You can loop your standard 35,000th of an inch guide wire, introduce it looped in the guide catheter, and then fix one limb of the loop with a 3.0 or a 3.5 semi-compliant balloon. You'll create a loop, and then you have one free edge of the wire or free arm of the wire that you can manipulate to increase or decrease the loop, and use that to grab the distal end of the kinked catheter.
Okay, thanks very much, Dr. Hatem.
My pleasure.
Okay.
Now, we're pleased very, very much. It was an outstanding presentation as well. Please give my best regards to all Omani and especially my colleagues at the Sultan Qaboos University Hospital. Please.
Hatem, this is the first share with us, but we are looking forward to seeing you more and more during this course. We're very happy to have you with us tonight.
It was an honor and a privilege, Prof. Thank you so much for the invitation.
Okay, thanks very much. شكرا منصور،
Have a
شكرا
good day.
كل الزملاء، شكرا مريان، وإن شاء الله نتعشى منكم تكونوا استفدتوا من لقاء النهارده، ونلتقي الأسبوع القادم إن شاء الله في يوم جديد. شكرا، مع السلامة.
السلام عليكم. مع السلامة.
مع السلامة. مع السلامة.